Commencing speaker of the day is Dr. Minu phaco-refractive surgeon, Chaitanya Eye Hospital. He'll be speaking about femto laser technology and overview. Welcome, Dr. Minu.
Thank you, Dr. Jason. Welcome to this session of Femtosecond laser assisted cataract surgery. So I am supposed to talk about an overview on this technology and the surgery part of it. Absolutely no financial interest at all. So we know that this laser acts at infrared 1030 nanometers, and femtosecond means minus 10 to the power minus 15. Hello, sir. And so that is that fast, just to show how fast this is and all this. So mechanism is it is delivered into tissue, plasma generated, tissue separation happens. Basically that's as simple as that. And you can create different patterns. There are in different company machines, different patterns are available. Anyway, it is a kind of nucleus separation in form of a cylinder or in form of chops or in form of softening into small cubes. And no financial interest, but this is the platform which I use. And so the LensX platform, it needs docking. It's a contact process. So you have a patient interface which has to come onto the eye surface, and it has to applanate on the cornea by contact. So this is how the patient has to look into a blinking light, which he may sometimes see, sometimes he may not see. But then still, if he keeps his eye steady and straight, you can always dock, especially in very small eyes, and you kind of so once you dock, you may see the centration of the limbus. So this has to be quite central. And then once it is done, should not get any air bubbles in the interface, and then you will see the marking of the rexus size, which you can make the position and the size of the incision. So here is the marking on the anterior capsule, where you can measure whatever 4.85, 5.1, 5.2, and incisions also you can make, and paracentesis even 1 or 2. And see, some patients, this is one difficult situation where patients cannot see specifically a spotlight. So we'll have to maybe redock and dock. This is one case where the docking is not very central. See, this space is more, so it is a little tilted dock. But then still we can readjust the location of the rexus and the nucleus treatment according to the position of the eye, because many times once you do, patient becomes more irritable, and also you may not get it right. So once or twice if you do it, still it is not possible, then you can proceed with this also. Here the problem is that he has a intumescent lens with clear or white fluid on top of the nucleus. So here you cannot focus on the nucleus. So that is out of the question. You cannot do it. You can do a capsulotomy, but here the problem is the cortex is fluidy. So once you cut, and some level it starts from below, and once it completes, this fluid starts coming out. Once the fluid starts coming out, two things happen. One is it blocks the laser. Second thing is the level of the capsule changes. So you finally end up with an incomplete capsulotomy. See the gush of fluid which is coming out. So the first point which opens up will get this fluid out. So then this happens. So many times yours will be incomplete if you have very intumescent leaky cataracts like this. And on a table, see, we are used to this kind of a look with the lumera and retroillumination. It will look so grand and nice like this, so lovely to look at. But then if we do a femto, and then most of the cases will look like this. So this will be a new feeling for you, with lot of air bubbles and different yellow color and no red glow and all those. But later on we'll get used to that. Sometimes, now it's very rare, but then still sometimes there can be meiosis. You would have done a 5 millimeter rexus, people have been large. You come to the table, the capsule will be over your iris, and the pupil would have become much smaller. But many of them respond to intracameral phenocaine, and if not, then you put iris hooks or rings to dilate. But then make sure you don't hook on the rexus margin also. Many times the anterior capsule will be free, and the rexus margin should not be caught within this one. So incisions, this is one advantage where you can see here it is as easy as this. You can just identify that you need to use should not use Sinski or just a cyclodylus spatula or something. So you have a pointed and an angulated one which goes into the plane of the corneal incision easily. So you can see now that this has been placed very anteriorly. So sometimes this happens when there is, especially when there is an arcus, and if you try to go anterior a little bit more, it goes too much anterior, and so I abandoned this. Nothing happens to this. So it is just like you have not done anything. Just make another paracentesis on some location close to your limbus. So sometimes when you are too late doing the surgery after the femto, you may lose this kind of, the bubbles inside is an indicator of where it starts and where it ends. So sometimes you may have to try to identify the location by drying it very nicely, and also epithelium has to be slightly peeled. And then here again, see the angulation of the instrument. So if you angulate it downwards, it will not enter. So we should remember that it's into the cornea, and cornea is bent upwards like this, and so your needle or your instrument has to go in that plane first, identify the plane, and then it goes in very easily. Sometimes it looks very difficult. Here again, this is a classical example of a large arcus, and you hit on it, never opens. So if it is very large arcus, it is just out of the question. It doesn't penetrate through opacities. So capsulotomy is another very good option where you can have, mostly nowadays, which are free floating capsulotomies. Now you can see that you can just peel it off. So sometimes when you feel that there is connection, so don't just pull off. I rotate it around like a normal rhexis, so that when you feel resistance somewhere, you can always do it right like a rhexis. Especially in intumescent cataracts like this, if you see, I always stain. I just don't pick up the capsule. So some areas, mostly around 90% will be just free. When you put visco, you will see it moving off. But then if it is not completely moving, that means there is a bridge or a connection somewhere. So identify the connection and include that connected area in the rhexis. It may become a little irregular. So go beyond it and include that and come. Now you can see, if you see very carefully, I am zooming up to show you that there is a small strand of capsule here. So if that was on the rim of the actual capsule, then it would be a weak area there. And so remember, so this is how it looks after the case, just to show you that it was a complete capsulotomy. But then if these kind of tags are there, during your chopping, these are weaker areas where already some spots are there and still they have not opened up, and they can be weak areas. So here again you see that there is a connection here, and in all the rest are free. So when I am catching onto the capsule, I don't just pull out, I just lift up that area and see where is the connection, and just go beyond the connection and include that area and make it a slightly irregular one, but then still see the part getting included in the rhexis, and it becomes more uniform. And this is how it looks at the end. So hydro procedure, many times it will be difficult to see because of the air bubbles inside, the fluid wave is not generally seen when there are a lot of air bubbles. But then we'll see the movement of the nucleus. You can just see the movement of the nucleus, and you can see rock the lens, and this nucleus, the air bubbles come out, and then your red glow is better. You can even repeat it. Nucleus disassembly, it depends on till where you have hit, but then maybe you can go till 700, 550 microns, and then the cut is not complete anyway. So you'll have to go through the chop and then hold it and then split it. So you can use pre-choppers. Sometimes the hydrodissection is not complete, because if you are not hydrodissected well, you could not see the wave. It will not rotate. But after you dissect once, one more fluid wave, 1 or 2 times you can hydrodissect again and make it rotate. And once you see that, see the central core comes off because you have done a central cylindral part, and then the others are all mostly pre-cut, and so you can easily separate. See, there's so much of air bubbles. See, when they are very hard cataracts and use a lot of energy to cut through, then you get a lot of air bubbles. Very disturbing it will be, but you can easily remove them, and during hydro you can rock the nucleus and bring out. So you can see the cuts are already done, but it's a grade 4 nucleus, and so you can see, once you open up, see the kind of air bubbles which come out from the nucleus per se. Cortex aspiration is a little different because it cuts through the anterior. When we have anterior and posterior offset, you get cuts through the anterior cortex also. So when it cuts through, you'll get a cut, so vertically cut edge of the cortex, and you don't have loose cortex to pull it. So if the pupil goes down, then it is we have to be very careful to go underneath the rhexis margin and aspirate. So careful not to catch the cortex, the capsule here. IOL implantation is fine. It looks very well centered and nice, and that is a major advantage of this. And see, in one case where I had injected an IOL into the femto, this one, see what happened when I'll show you, this is an intact rhexis, but then when I injected the IOL, it went in very fast. Sometimes it gets shot in like a rocket, and then because it hit on the bag, See, this way it hit on the bag, and then I had a intercapsule tear. I can show you at the end. So just to tell you that this may not be as strong as we feel, and it's been published that there can be weaker areas. See the margin which is broken here. So I don't want to go into small people. You cannot be doing, if it is smaller than 4, it's as simple as that. You cannot do a capsulorhexis through the iris. That is not possible. Maybe you can do it smaller, do the phaco, pupil, get the pupil larger, and then extend the rhexis margin. Posterior polar is the greatest advantage. You can create a femto delineation and take out the nucleus like what you see here without any rotation or any hydro procedure. And subluxation also, you can locate the rhexis away from your subluxated area, and having a rhexis is very, very important to place capsule stabilizing devices. Thank you very much.
Thank you, Dr. Minu Mathan, for the exchange of knowledge.